fetal heart rate, maternal vital signs, and the woman's nearness to birth. C, identification of ruptured membranes, the woman's gravidipara, and her support person. D, last food intake, when labor began, and cultural practices the couple desires. B.
Damn it.
B says this: fetal heart rate, maternal vital signs, woman's nearness to birth, means checking her cervix, okay. Fetal heart rate, number one thing, you have a Gravidix 3, Para 2 entering the unit, you want to get her on the monitor immediately. That's it, okay? Once she's on the monitor, you're running a strip, then you're going to get her vital signs. And once those two things are done, you're going to check her cervix, basically in that order. Who was in labor and delivery this week? Yesterday. Raise your hand really high. Did you get to see anybody get admitted? Did you see somebody admitted? And what was her history? What was her story?
Well, the very first thing they did was they put the
Monitor on? Okay, so we got to see that happen. Okay, yay. Perfect. We want to make sure this baby's doing well. Okay, first thing. We want to be running a strip during everything else. The contraction, basically, the contraction pattern, her discomfort, and her history is all important information. Okay. C, identification of ruptured membranes, her gravidipara, and her support person, that's all important. D, last food intake, when labor began, and all that's important. But we want to know the most important thing we want to do right off the bat, okay? And this is what nursing is all about. What takes priority over all four choices? Getting the baby on the monitor, number one. Getting some baseline vital signs on her, number two. And checking her cervix because she's a multip and she's in active labor, okay? All right. Number 4, a prima gravida has 39 weeks of gestation is observed for 2 in the intrapartum unit. The fetal heart rate has been normal. Contractions are 5 to 9 minutes apart, 20 to 30 seconds in duration, and of mild intensity. Cervical dilation is 1 to 2 centimeters and uneffaced, unchanged from admission. Membranes are intact. The nurse should expect the woman to be A, admitted and prepared for cesarean birth. B, admitted for extended observation. C, discharged home with a sedative. D, discharged home to await the true onset of true labor. D. Okay, she's already been observed for 2 hours. Okay, so she's been on the monitor. We've been watching her for 2 hours. We have checked her cervix and we have rechecked her cervix. There's been no change. Her contractions are only 5 to 9 minutes apart, and this is her first baby. They're only lasting 20 to 30 seconds, okay? And they're mild. So based on that information, we just want to send her home or send her walking to the mall or just send her somewhere else. The last place she needs is to be with us right now. We have already determined that everything's normal. She's really not in true labor yet, okay? If we were going to, some people said B, if we're going to admit her for extended observation, we need a reason why. We either need the heart rate looking, what we call equivocal, like equivocal. We're not really sure if the baby's doing okay. We need some reason why to keep her longer than 2 hours when it's early for her. Does that make sense? Maybe she's vomiting every 30 minutes because these contractions are causing her to vomit. Well, if she's vomiting, most likely we don't want to let her go. We want to get her at least hydrated, okay? Maybe give her something for the nausea. But we have to have a reason to keep observing her, all right? Okay, number 5, a laboring woman is lying in the supine position. The most appropriate nursing action is to A, ask her to turn to one side. B, elevate her feet and legs. C, take her blood pressure. D, determine if fetal tachycardia is present. A, we want to get her off her back, right? We don't want supine hypotension happening. We want to get her to her side. 6, during the active phase of labor, the fetal heart rate of a low-risk client should be assessed every what? 15, 30, 45, or hour? 30. Okay, she's in active labor. What does active labor mean? She's 4 to 7 centimeters. So she's moving, all right? Because she's moving, we want to assess at least see that strip every 30 minutes, just to make sure her baby's doing okay. All right? That's in your book. 7, which position is best when a laboring woman requires urinary catheterization? A, supine. B, supine with a small pillow under one hip. C, lying on the side with one knee pulled toward the chest. D, slight Trendelenburg. B, supine with small pillow under one hip. We don't want her flat for the catheterization. Otherwise, we're going to see a decrease in oxygenation to the placenta and to the baby. Number 8, which nursing assessment indicates that a woman who is in second stage labor is almost ready to give birth? A, the fetal head is felt at 0 station during vag exam. B, bloody mucus discharge increases. C, the vulva bulges and encircles the fetal head. D, the membranes rupture during the contraction. C, the vulva bulges and encircles the fetal head. Did anybody say a vaginal delivery that was in L&D? No? No? No. Nobody saw a vaginal delivery? Oh. Bummer. Okay, so at least one student got to see that. That's cool. Okay, 9, Regina Smith is a 25-year-old prima gravida in the first stage of labor. She and her husband have been holding hands and breathing together through each contraction. Suddenly, Regina pushes her husband's hand away and shouts, "Don't touch me." This behavior is most likely A, normal and related to hyperventilation. B, common during the transition phase of labor. C, a sign that she needs analgesia. D, indicative of abnormal labor. B, common during transition. You already know in the STEM that she's in the first stage, and if she has a sudden behavior change, sign of transition. 10, if a woman's fundus is stopped 30 minutes after birth, the nurse's first response should be to A, take the blood pressure, B, massage the fundus, C, notify the physician or nurse midwife, D, place the woman in Trendelenburg position. B, massage the fundus. You want to massage it and see if it firms up. All right. Okay. All right, now you can breathe your first quiz within the history. All right. Okay, we're going to start with pain management. Yes.
For the one with the primate who was who was there for 2 hours and didn't make her home, if she was GS positive, were they not supposed to do antibiotics or would they send her instead?
Hopefully they would still send her home because her membranes are intact and you're getting that in the stem and her contractions are just so far apart. With a primate, we would always tell them wait till they're 2 to 3 minutes apart for at least 1 hour before you come. Because it's your first baby, and it's going to take, anyway, I don't know how many of you had babies and it took a long time for that first one to arrive, but it tends to take a really long time. Okay, so general concept of pain management, which I'm sure you learned some of this last semester. Pain is subjective. So my pain level is not going to be your pain level, right? So when we ask a patient, what is your pain, 0 to 10, 0 being no pain, 10 being severe, what is your pain? This is their perception of their pain. And we need to take it very, very seriously. This slide is just showing you where pain stimuli enters the spinal cord and how regional anesthesia is going to block transmission from affecting the uterus, cervix, vagina, perineum. And the examples of our pain management are the very bottom. Examples are the spinal, lumbar, epidural, and pudendal block. So these are the 3 types that you're going to need to know. Okay, so if our patient is going to get that, then what happens? The pudendal nerve. Regina, do your midwives use pudendal block?
Is that, I never heard, that's not the water, right?
It's a local, this is a local that actually goes to the pudendal nerve. And the diagram behind this word is showing there's a little, the midwives I worked with at Desert Valley, we use pudendals pretty much on every patient.
We're totally out of hospital, not in one, so the only thing we'll use like water and sometimes we'll do the inner, I Like right under the skin, water?
Yeah, so local anesthetic, like a
No,
local?
just the sterile water.
Oh,
Yeah,
that's cool.
just like the gate theory.
Okay. Okay, so pudendals go into the pudendal nerve, and they provide a much nicer block than just the local anesthesia. So if you have a patient saying, I want to go natural, pudendal block blocks the whole perineum, and like for their, when they do the stitches, it's just a great block. It works really good. Plus they can get right up to the bathroom. As soon as their delivery is done and they're all repaired and everything's done, you can ambulate them to the bathroom. Their perineum is going to stay numb for several hours. It's really great for that initial pain of the episiotomy and inner repair that was done. It doesn't alter her vital signs whatsoever, maternal oxygenation, nothing is affected by the pudendal block. So when the doctor or midwife uses a pudendal setup, you're not going to have to do any more vital signs. As opposed to the epidural, it's going to change everything you do nursing-wise. So, all right. That's the pudendal. This is out of your book, showing exactly where it goes to the pudendal nerve. There's a little guide, looks like a little trumpet horn thing. They put that in first, and then they just put the needle through that to get to the nerve. I've just seen really great results with pudendal. This is a picture of a epidural being done in the OR. Looks like the OR, yeah. And so with your epidural, since you're going to see a lot, anybody get to see an epidural placed in labor and delivery? Oh, you did? Oh, that's great. Did you help?
No.
Okay. Because what you can do to help is position the patient. Sometimes you have the husband or the mom or the neighbor, the friend, whoever, not wanting to be in the room during the placement. Sometimes the anesthesiologist doesn't want a family member in there. So then that'll be our job to keep the patient completely positioned and very, very still for the procedure. Extremely important. Duramark is something that's used at all 3 facilities. And it's great because it reduces pain for 24 hours. So they're going to need much less POs meds. What else can I say? No direct effect on the fetus unless placental circulation is compromised, but that's due to maternal positioning. Our blood pressure drops, and doesn't get treated. And I mentioned that last week. If mom's BP drops, we've got to get that back to normal range. Otherwise, we're going to see a huge bradycardia in the fetal heart rate. Okay. And let's see. Effects of epidural. It's not actually the medication that causes maternal hypotension. It's the removal of mom being into pain that stops all the chemical receptors. These are examples of drugs at the bottom being used. Fentanyl is used commonly in Duramark. This is showing, just a little beautiful picture from your book of the spinal cord. I love your book. I like all the pictures. This shows epidural placement. Did you notice when you got to see the epidural, they use, a needle goes in, and then they thread this little tiny catheter through that needle, and then the needle comes out. So this slide shows the needle in over here, and then they thread the catheter through that needle, and then they pull the needle out. So we want the patient to be completely still when the needle goes in, when they're threading the catheter, and until the needle's removed. Then the patient can actually kind of breathe and relax again. Okay. And this just shows the general area of numbness. 2 nurses at Western Med, I was there 1 semester at Western Med, and they told me that a patient got an epidural, the epidural went up, okay, instead of down, and the patient went into respiratory arrest, and the anesthesiologist left the unit, and they proceeded to bag that patient for like 4 hours. And for me, because I'm totally about staying into my scope of practice as a nurse, doing what I am licensed to do, they didn't get him back there. I don't know where the anesthesiologist went, but they should be available by phone to get right back to that unit. But they bagged that gal for 4 hours before, I know, I would never do that. But they did that, and they're happy that they were successful at maintaining oxygenation. So this is where the area should be numb. I've only seen a spinal go up like that, and that was once in the operating room when I was a circulating nurse, and this was at Kaiser. And he put the spinal in, laid her down, and it actually went up, and the patient was saying this to me with her lips. Saying, I can't breathe. And I'm reading her lips going, she can't breathe, she can't breathe, she's saying she can't breathe. And so because she's on the table ready for surgery, he put her under general immediately and intubated her, and she was fine because, it was going to be surgery anyway. But that was the only time for me personally I experienced that, and it really does give you palpitations when you're the nurse. And anesthesia goes up too high. So you want to just, the sitting position I think is what most of the doctors that we're working with use for patients. And I always tell the patients, I always show them with my own back, we want your whole back rounded because we're trying to open up the spaces in between the bones. Because that's where the doctor's going to be going in between the bones. So spinal, we're only going to use spinal for C-sections. When I was a brand new L&D nurse, they used to do those saddle blocks. Have you guys ever heard the term the saddle block? They used to use that when a patient was 10 centimeters, give them that saddle block, and they were completely numb, and they couldn't push the baby out, and they had to use forceps. But thank God that went out in the very early 80s. So these are used for C-sections. You very likely get to see a spinal use. But once the spinal goes in, you go really fast. It's really quick. You might get to do a Foley catheter on a patient that gets the spinal. But just watch your nurse. I don't know how much I'll get to do in relationship to helping the anesthesiologist, but do whatever the nurse allows you to do as far as helping get the spinal in place. Again, if it goes high, then it can affect the respiratory. And it shouldn't affect the baby, it shouldn't affect the placenta at all. Okay, here's, again, spinal placement, where the needle goes in. For the spinal, they put the needle in, they put the dose in, the needle comes out, and that's it. So there's no indwelling catheter as with the epidural. Okay. And then, with our narcotics, did anybody see any narcotics used when you were in L&D? There's 3 of you in L&D, 1 person assisting. Any narcotics given? Just one epidural. Did your patients have epidurals? What was the story?
They didn't labor.
They what?
They didn't finish laboring before we had to go.
So you didn't get to see the delivery. But was there an epidural or narcotics used?
Yeah, I think Morgan's the only one who saw.
Okay.
Yeah, the patient first, she was given an epidural, and she had a lot of stuff going on. So I didn't get to see when they put that one. We saw one later.
Okay.
And then I saw fentanyl and something else for that. And then she went to OR for a C-section, and they put something else.
Oh, so she
I
didn't
have it
have
written down at home.
Okay, yeah. It's all
So
new to
the
you.
doctor just added stuff in the line. So.
Okay, so she was going to be a vaginal delivery and ended up in C-section. So yeah, what they do is they have existing epidural, they just bolus it up for the surgery. Give her extra amount for surgery. Okay, so Nubane is an excellent medication, my favorite of all meds that I ever worked with. You can give it IM, sub-Q, or IV, but it just has a great effect on mom, much better than Demerol ever affected patients in the past. And you can mix it with Phenergan, which is good for nausea. But it's just good to be aware of Nubane. It's a great med that we use. It doesn't have a significant effect on the newborn. In case you give, sometimes you'll give an analgesic, and then the patient's maybe 6 centimeters, and they get that analgesic, and they completely relax and fall asleep, and then they go from 6 to 10 centimeters really fast. Babies with mom having Nubane don't tend to have the respiratory depression associated with Stadol and Demerol that I've seen. So, okay, that's Nubane. Stadol, again, I don't really like it because of the effect on the newborn, but it does work well. Here's your usual dose. You can give it IV or IM. But it might even cause a transient sinusoidal fetal heart rate, which means it affects the heart rate and gives it like this kind of S shape. That's Stadol. And then Demerol. Just give a lot of Demerol. I don't really like, some patients actually have, they like have hallucinations on Demerol. They're kind of out of it. Vomiting is really common with Demerol, nausea and vomiting. And it's not like it. Okay. But you give it IV, IM. Sometimes we give half of our dose IV, half of it IM, because the IM has a longer lasting effect on the patient. Again, respiratory depression is common in the newborn, especially if it's within 2 hours of delivery. So we would have our Narcan immediately available to this baby. And then fentanyl, again, that's great in the epidural. It's really a great medication. Works really good. Observed for dizziness, drowsiness, rash, pruritus. If a patient starts saying they feel itchy and they've had the epidural, it's pretty common. I would say at least 50% of patients have the itchiness as a side effect from the medications in the epidural. So we want to let anesthesia know if they're having itchiness. A lot of times they'll have Benadryl ordered in case they do have the pruritus. So just be aware that the itchy feeling, pruritus is common. And again, Narcan is a great antidote, basically for all these. Okay, that's the baby. So give us Narcan. This is a medication you need to know this semester if you haven't already learned it. For the newborn, it's dosed 0.1 milligrams per kilogram. So all pediatric doses, beginning with the newborn, it all goes by their weight. Okay, there's no just set dose. It goes by the weight of the baby, and that's how we'll medicate. Okay, so general nursing actions. If any medications going in for our labor patient, we're going to have continuous fetal monitoring going. We're going to keep a close eye on the baby to make sure the medications are not having an adverse reaction to the baby. If they've had a narcotic, you should highlight the word variability, where it says fetal heart rate variability, because all analgesics will affect the variability of that heart rate. And so you want to highlight that as a known side effect, that for the next few hours after this patient receives an analgesic, IV or IM, sub-Q, it'll affect the fetal heart rate. We'll have a decrease in variability, and if we're just seeing a decrease in variability, we're going to be concerned, unless we know she's got an analgesic. Then we're going to expect that, because we just gave a mom a narcotic, now the baby's having the effects of a narcotic. So instead of their heart rate being super reactive and lots of changes, it's just kind of, the baby's going to go to sleep, because we've just, sedated the baby. We've not only sedated mom, we've sedated the baby. So we expect a decrease in variability, okay? If we're thinking about medicating a patient with an analgesic, and there's a variability that's not very reactive, what we call reactive, we're not going to medicate that patient, okay? So you understand that. We expect the narcotic to do that to the baby, but we're not going to medicate somebody that already has a baby showing kind of a flat variability, all right? IV hydration, we're going to bolus the moms 500 to 1,000 mLs of fluid. That's a liter, half a liter to a full liter of fluid prior to the epidural going in. So please, if your patient gets the epidural ordered, watch what the nurse is doing. She's going to be bolusing the IV fluid. And that's another reason why we're going to be watching the bladder. Vital signs with the epidural, we'll be doing BP and respiratory rate every 5 minutes after it goes in, for the first minimum of 15 to 20 minutes. After that, we'll be doing blood pressures every 30 minutes. Okay, super important. And then for the significant hypotensive effects of the epidural, ephedrine, you should highlight, circle ephedrine, you need to know this medication. Ephedrine is given to bring back the maternal blood pressure to normal range. Okay? Okay, so nursing actions. Positioning, we always want moms on their sides. You guys that were in labor and delivery, were your patients on their sides?
Yes.
Head of bed elevated at least 30 degrees? Okay, good. Non-pharmacological methods, we should know what that means when we're talking about a labor patient. So if we're encouraging non-pharmacological methods, we're encouraging her to do breathing techniques, rubbing the back. We can have their coaches actually massage their back, have them have a focal point, something to stare at, to breathe through the contraction, to focus on. Application of heat and cold, usually you need an order for that. So if they want like a heating pad on their low back maybe, we need an order for that, but we could get that from the doctor. Okay. So here's just a nursing diagnosis related to contraction. Facial grimacing and crying, noting the body language of somebody in pain is really important in labor delivery, because a lot of patients are not going to express their pain due to cultural variation. So if we see a patient looking like they're super uncomfortable and in pain, we want to talk to them about that. You know, you're really tense, you look like you're in a lot of pain, are you sure you don't want something for the pain? A lot of patients will think, oh no, I heard that if you give something to me, the baby will turn out, and they have all these different things they tell you. So we want to alleviate their fears, share the truth, the facts with them, and help them to make good decisions regarding pain. I don't know why I did this in these PowerPoints. Okay, that's what I'm laughing at. Like, what was I thinking when I was... But this is our goal. We just want to get their pain manageable. If they want the epidural, we can get the pain down to actually 0. Okay. And then pain should be assessed every time you're doing vital signs on your labor patient. So you're not just going to be assessing pain whenever. You're going to be doing it very, very routinely and regularly along with vital signs. And if you medicate a patient, if you're at the concept map seminar today, I spoke to that regarding concept maps. Okay, so if you have a postpartum mother-baby unit patient and you're medicating her for pain, that should be in the comments section under neurosensory. That patient complained of pain 6 out of 10. I medicated her with Motrin 600 milligrams, and 30 minutes later, her pain was 2 out of 10. But all that should be in the comment section. Okay, what we're doing. If facial grimacing is present, you should be charting that, and how tense she is. We're monitoring vitals, IV hydration, and we're getting her to empty her bladder, hopefully every 2 hours, and managing her meds, position for comfort. I usually offer the patients a pillow to go between their knees when they lay on their side, because that keeps the back in perfect alignment. So, the patients tend to really like that, especially when they have that epidural and their body's kind of feeling heavy. It's a great comfort measure. And encouraging the breathing methods if they're going to go natural. Which I don't know. You might see somebody going natural. We're assisting anesthesia with positioning, with a significant other. If you see the significant other looking pasty white and diaphoretic, you want to get them sitting down, and I'm not even kidding, because you're likely to see somebody not handling it all well at all. And so you want to be observing anybody that's in the room, especially for the delivery, to make sure they're doing okay. Because patients tend to not, people say a word and then they just pass out, or anyway. So that's one of our jobs too. Create a non-stimulating environment. Like lower the TV, lower the conversation. If people are just in the room hanging out, partying with we don't want them in there. We want them to go out to the lobby, somewhere else. We really want things really calm and quiet as much as possible for our labor patients. And some people are nervous and they just want to chatter and talk. Yeah, we want to get them out of the room. Okay. We want to teach breathing techniques, and we want to explain, hopefully when they're very early, the benefits of the different types of anesthesia or analgesia, when they can understand it. And then this is just evaluation. Okay, that's it. All right. I'm trying to go fast. Any questions on pain management? Also, I want to say that hydrotherapy research validates how well putting patients in a bathtub helps reduce their pain. I mean, we don't really talk about it. I don't speak to it because it's really not used at any of our 3 facilities. I don't think you'd be tested on it. But just know this, if people ask you now that you're a nursing student, you're going to get questions from all the neighbors, all the family, because you're in nursing school, right? But hydrotherapy is highly beneficial in reducing pain and labor and promoting a very fast labor. And I saw that with my own eyes out at Desert Valley where we didn't offer epidurals. So, but there is research behind that, so. Okay. All right, we're going to do, I'm going to read to you this before we start the C-section PowerPoint. This came out April 1st, 2010. Doctors induce labor, give C-section to non-pregnant women. Listen. The North Carolina Medical Board has issued letters of concern to 2 doctors at Cape Fear Valley Medical Center in Fayetteville, North Carolina, after several doctors and interns tried to deliver a baby from a woman who was not pregnant. Although the incident happened in November 2008, the board issued the letters this year during its January-February actions following a more than year-long investigation. I read this to you guys because you're all nurses and you would not want your name on this chart, okay? Because everybody in this case is going to go sit in front of a jury probably and tell why they were part of this. As a nurse, we are supposed to get fetal heart tones, okay? That's one of our jobs. The baby's heart rate is whatever it is, and tell that to the doctor. If you're not getting any fetal heart tones, you need to tell that to the doctor too, that I don't think there's a baby in there, I'm not picking up any heart tones. Okay, when I see this is happening in this century, but I've heard about this my whole L&D career, that people actually induce labor on patients who are not pregnant, and there's a pseudocyesis. This patient was suffering from pseudocyesis. I've seen patients in my department with this, also known as false pregnancy. In their head, they think they're pregnant, okay? But it's up to us to do our assessments and the doctors to do their examinations to determine if you're pregnant or not, okay? But this is a major surgery done on somebody not pregnant because she has a mental disorder. All right, so just food for thought. It happens. And I just don't want it to be happening to you. Yes?
What if you don't have technology?
If you're like in a third world country?
Can you hear it? What is that?
Yeah. Well, actually, we used to use these stethoscopes. This thing went over your head. They're called a fetoscope. Yeah, and I actually use those, and they do really work well. But there's also little tiny handheld Dopplers that in the clinic, that's what they use when you go in to be checked. But the doctors will pull out of their pocket and they'll listen to heart tones that way. But those things are so sensitive. You can pick up from the time on is 6 weeks pregnant. You can pick it up with that little Doppler. So there are things available now. This is, 2012, by golly. So anyway.
Vaginal exams would show different cervix.
Yeah.
So nobody bothered checking her cervix. Okay.
The ball was dropped by a whole lot of people. All I'm saying is, as a nurse, you have a voice. And if I were the nurse that was asking to be circulating or scrubbing in on this case, I'd be wanting to make sure she's pregnant. You know what I mean? Because that's going to be my license on the line right now. And oftentimes, doctors get off and nurses lose their license. It's oftentimes what happens. The benefit of working at Kaiser so many years, we were constantly learning all the latest legal, ethical issues that could affect our license. So you have a right. You have a license. You're very smart. By the time you finish this program, you know so much. So all I'm saying is, don't let that be you. Okay? Promise? On your honor? I was a Girl Scout. Okay, so let's hit for C-section. Anybody have C-section in here? Okay, so just one person. Anybody have a wife, girlfriend with a C-section? Oh, wow. Okay. So you were like a high-risk patient?
Well, I had my kidney errors connected to the urethra instead of the bladder.
Oh, wow.
Yeah, I have like a whole and then another line because they took my kidney out from the front.
Oh, wow. That's major.
Third world.
That's amazing. What hospital?
Somewhere in Sweden, I don't know.
Oh, okay. Wow. That's a crazy, like, that would be a really unique scheme of detail. Yeah.
And when I was in my babies, like, would I have to do a C-section? I couldn't do that for because it's so long now.
I would think you could go for a trial of labor after cesarean. I would think that.
I mean, it's been like 24 years.
Wow, yeah. But yeah, I would think you'd be able to do a trial of labor, especially here in our country where we're more, I don't know how they are in Sweden though, but here we're more proactive, I think. But you have to find the right doctors that are eager to do that. Okay, interesting. Thanks for sharing. And then yours was a C-section for what?
I had two. The first one, the C-section was breached.
Oh, breech, okay.
Yeah. And then I just did a repeat one because I was kind of nervous. And
Yeah.
Because I was reading about, you can rupture from the inside.
Yeah.
And so my doctor was pushing for feedback, and I was like, no, like, I just want to do, I know what to expect. And so when he was doing it, he said, I'm really glad you did it because he was ruptured.
Oh,
He said
okay.
it was like really thin. Really
Okay, yeah. And there's always that chance that the uterus can rupture. The benefit of being on the monitor and having like internal monitors though, that if the uterus was to rupture, you can get rushed right back to the OR and, get the baby out and salvage the uterus. But I don't blame you.
Yeah, I was nervous.
Moms have a feeling. You always have to go with,
Yeah, and I normally don't speak up like for things, but this was the one time.
yeah, that was smart of you. Okay, good. Okay, so the C-section involves abdominal plus a uterine incision. Okay, so if you get to be in the OR, which hopefully all of you will get to see at least one C-section, maybe more. If you watch the scrub, we used to scrub and circulate on our cases. So there's actually two knife blades on the table. There's one that opens the skin up. And once the skin is opened, that knife blade is discarded, and then the next knife blade is used for all the inside incisions. But the abdominal incision getting into the abdomen, that's going to be the scar that's visible to the naked eye. But the type of scar that's on the uterus is what's very important for us to know what kind of a scar that is if the patient wants to have a vaginal delivery following that. Okay, so if she's had a birth in a foreign country, we really want to get records, because I used to have a lot of patients that came from Mexico or South America, and they'd had C-sections and they wanted to do a vaginal birth, but we really needed their records to know what kind of incision was on the uterus. Okay, so that's important. And if you ever have a C-section, it's important knowledge to have. How did they cut open the uterus? Indications. Here's a list of indications. She had a previous C-section. Failure to progress means you're laboring along, and maybe you get to 4 or 5 centimeters, and you just stop progressing. And they give you so many hours to continue to progress, and just stop progressing. So that's one of the most common reasons. And then the reason under that, cephalopelvic disproportion / macrosomia. So CPD, you'll probably hear CPD or doing a section for CPD. That's cephalopelvic disproportion. That means the pelvis is too small to fit the fetus through it. Okay. So macrosomia means the large baby, large for gestational age baby. So the baby's large, the pelvis is too small. Abnormal presentation, we talked about that last week. How you might have a shoulder coming out, face first, breech. Fetal intolerance to labor means that the baby's gone into fetal distress, that we have a heart rate with late decelerations on it, or we're having a baby that's tacking, or the baby's heart rate is looking really bad to us, and we know we need to get the baby out. Okay. We used to call it fetal distress. Fetal intolerance to labor is the same as fetal distress. Then placenta previa means the placenta is down into covering up the cervical os. So the placenta is attached at the bottom of the uterus, and now it's covering the cervical os. So they have to have a C-section. Placenta abruption means the placenta is abrupting. It's pulling away from the wall of the uterus too soon. Because that shouldn't pull away until after the baby's out. So when the placenta is abrupting, it's pulling away from the uterine wall, causing bleeding for the mother and bleeding for the baby. Okay, that's an emergency. And then prolapse cord is when the cord comes down in front of the baby's head. Baby's coming out head down, but then the cord's here. So we have the cord getting smashed. So when the cord gets smashed, that's the oxygen supply to the fetus. So this is another reason for an emergency cesarean section. Okay, sorry. What was I saying? Questions?
A couple people have been telling me that they did cesarean and they're told that there's been calcifying, something like that.
What's calcifying?
The placenta.
Oh, yeah. Especially in smokers. We'll get these, like, knots in the placenta. Or the placenta's getting old or showing hard masses in it. Yeah, so that's usually when they're overdue or if they smoke. I know the smoker placentas have lumps in them, like calcification. So the uterine incision I already mentioned is our primary focus. The low uterine segment is most commonly used, and that's the preferred incision. It's in the part of the uterus. There's less blood loss, less likely to have a bladder trauma. Sometimes the bladder gets nicked during C-section, and then they have to repair the bladder too. That's pretty serious. But anyway, the lower uterine segment incision is what's preferred. And then this is just pictures of the vertical incision, or the classical, and then the panaceal incision. The lower uterine segment vertical is preferred for like twins, triplets, abnormal presentation, previas. Because of the placenta previa, you don't want to be cutting into the wall of the uterus where the placenta is attached to the wall of the uterus. Large babies, macrosemic fetuses. And then the classical incision, that's usually when we've got to get this baby out or we're going to lose the baby. It's a fetal distress. And it's the most highest of emergencies. They're just going to do that classical incision and get the baby out. Okay, so it'd be exciting if you got to see one of those, but I hope that doesn't happen to patients. So that's the classical. Okay, so here's the three different variations. The low transverse, that's what we really like. The low vertical, and then the classic is that higher. And this is from your book, these pictures. So nursing action. The doctor is to do an informed consent, but usually the nurse is the one that gets that consent signed. It is up to the doctor to get in there and tell the patient all the risks and benefits of why they need to have surgery. It's not our job. Sometimes I would explain to patients when I know there's craziness going on in a department like the full moon, and because the full moon is over this last weekend, the L&D departments were busy. But but it's really the doctor's responsibility, but we get it signed and we make sure it's on the chart. That's a nursing responsibility. And I say it's one of the most important things to do is have that consent signed and on the chart. The anesthesiologist needs to come and explain the choices for anesthesia, but we alert them, we call them and let them know the patient and the history. IV fluid, we need to get IV started and it needs to be LR running. We need to get the Foley in. If they're having the epidural, we usually put the Foley in after the epidural is in, or the spinal. If you get to be in the OR, ask to do that Foley. Tell the nurse, can I do the Foley? It's a great patient to do it on. Skin preparation. There's a skin prep that you do prior to taking the patient into the OR, where we shave the abdomen. And then once they're in the OR, the skin prep is a very meticulous prep. They probably won't let you do that, but watch the nurse do that. It's a betadine prep, and it's very carefully done to clean the site really nicely. And then there's the Citra. It's an antacid. It's up to the nurse to give this prior to taking the patient back, but it's an antacid. It's a little 30 ml little shot glass. Blood specimens would just mean getting the CBC. Most anesthesiologists will not start a C-section without having a CBC on the chart. So that's up to us to get that drawn and sent to the lab and have that on the chart for them to review. And then we can start teaching our patient, if it's a planned C-section, we can start teaching them post-operatively that we're going to be having them turn, pop, and debrief. We're going to have them use the incentive spirometer, and we can start all that teaching. Leg exercises. and then just offer them support. Some patients feel really defeated when they have to have a C-section psychologically. And then this is just what the vacuum, we talked about the vacuum last week. Sometimes with patients where the head is wedged way down into the pelvis, they're actually in the OR during the C-section, they're going to use the vacuum again to help get the head out of the pelvis. So this is just what the vacuum looks like, the attachment, the little cup that gets placed on the baby's head, and then the little chignon, they call it, when the baby has a little swollen area from the vacuum. Did anybody get to see a vacuum used? No. Okay. Hopefully you will.
Is it going to affect the baby if we use the vacuum?
As long as the vacuum is used properly, it should not affect the baby. When they're used, yeah, I've seen some bad uses of vacuums. I saw the effects of them before. Hopefully you get to see it. If the pressure is on the green zone, because we actually crank up the pressure and keep it in the green, they should do 2 tugs. Then you should release the pressure, wait for the next contraction, and then if you do it all correctly, there should be no problem with the baby. It's when they're used incorrectly that they can cause cephalhematoma and cause damage to the baby's head. Okay, so post-operatively, you'll get to follow your C-section patient from the recovery room, from the OR into recovery. So turn, cough, and deep breathe is extremely important, and then set a spirometer to have them, they're all different, but sometimes it's how many balls you can raise up by using your SENS spirometer. We want them up as soon as they can get up. Usually it's 10 to 12 hours, as short as 8 hours. But early ambulation is the key to a quicker recovery. The H&H, we should be looking at that. C-sections can bleed more. They usually will bleed more than a badge. But EBL shouldn't be more than 1,000 ml. Badge shouldn't be more than 500 ml. But you want to be checking their pre- and post-operative H&Hs. It's a nursing responsibility. Let the doctor know if there's a significant drop. INO, they're on strict INO. During surgery, it's important for the circulating nurse to make sure the doctor can actually see the Foley, the anesthesiologist seeing the Foley draining. What else? Foley should be in 12 to 24 hours, and then the IV fluids until they can take PO fluids. We want to get our patients onto PO fluids as soon as possible. Okay. Hand washing, I can't stress that enough. I'm sure, did you get that shoved down your throat last semester about hand washing? Okay. The most important thing you can do, even if you're wearing gloves, wash your hands afterwards. Assessing their temp, it's a post-op surgery. They're going to have a slight temp, and that's normal. Okay? A slight temp post-op is normal. All right? The temp should be done Q4. Get the patient up, advance their diet as tolerated. All patients are different. Some patients can tolerate ice cubes right away in recovery. Others, if you give them an ice cube, they're going to start vomiting. So every patient's different. If they have the slightest bit of nausea, we don't want to give them anything by mouth yet. Increased dose. Simethicone is a med that they should get. What does simethicone do? Yeah, it reduces the amount of gas because their bowel sounds, the bowel activity decreases during surgery and then it slowly returns to normal. So we give simethicone to reduce the amount of pain that they have from gas. Pain management, again, we've talked about that quite a bit. With the Duramorph, they should have less pain pills by now for 24 hours. But we want to keep them comfortable. That's the goal. Because if they're comfortable, they'll get up and they'll move. Active passive range of motion. So if they're in the bed, they have the spinal, we'll have them doing the leg exercises. We should have the sequential stockings on their legs right after surgery for X number of hours to keep circulation going in their lower extremities. Wind them up moving. Incisional care, you might get to do the staple removal. If your nurse tells you on another baby unit, show the staple removal, do that. It's really fun. We love to do it with you. It's an easy, fun thing to do. They take them out before they go home. We want to be teaching hand washing, and we want to be showing them through our actions how important hand washing is. And then the fundal and lochia assessment. On a C-section patient, the fundus is going to be lower, and there's going to be less bleeding. And if you're in the OR, you'll see why. Because they completely clean out the uterus before they sew it back up. And then prior to the patient getting off the table, we do the gnarliest fundus, pressure on the fundus, getting all the lochia out. So they just have less bleeding. And then pericare is still very important. So we're teaching pericare. Did anybody go to Mother Baby Unit? Were we teaching pericare? Yes? Yes? No? Yes. And you should be, even though the patient's been there, we need to continue expressing good pericare. There's my joke. Nurse, get on the internet, go to surgery.com, scroll down and click on the Are You Totally Lost icon. And I think it's funny. Okay. All right, so let's take a break right now. And then we come back, we're going to go over our vocabulary words. Okay? Come outside after. Oh, yeah? Burping? Oh, you're funny. You're having I think magnesium is really good for you. Calcium, magnesium. I'll ask my friend that's a nutritionist. She's awesome. See what she says. Okay. Yes.
Okay, for number 5, it says, what is the priority nursing action to do if the mom is lying down, right?
Yeah.
And,
Supine.
and I was thinking either to ask her or to check the fetal hypertension.
Turn her on her side.
But when will we do check the fetal hypertension?
No, it's fetal tachycardia.
Yeah. Tachycardia.
We're always checking to see if fetal tachycardia is present. We're always looking at the strip.
Yeah.
So we're always doing that. Yeah. So, yeah, we're always doing that. But if she's in supine, we just want her on her side or tilt the pelvis.
I know it. Thank you.
That's what you're working. Water. Okay.
It's not that I took it in the reading. Well, at first of all, it didn't happen right away. The doctor the doctor relaxed. So we just stood there, just like we monitor.
Right.
Making sure they're okay.
Yeah.
And that's all the way I did. I kind of know, and I couldn't control it. I don't know what's going on. And I couldn't talk. I started like crying, but not that I was crying. I was just like with the tears falling out. And I started jumping on the bed. During, before that, the court is like, you know what? I'm sure that, yeah, they had it before.
Yeah.
It's not like my first child, you know, the same.
Right.
So she kept turning, okay, turn to the other side, and maybe, you know, with gravity,
Yeah.
the medication's gonna go. But then, no, it's not working.
Oh,
But then in a second, that's when
oh my God.
and she put oxygen on me, and she, I think she went together.
Yeah.
And he came back in all I remember is the apart, all the little taking it
Oh, they took it out?
and they have to wait half an hour to try again.
Oh my God. So that's probably the wrong place.
That's my dad is a doctor.
Oh, yeah.
He wasn't there when it happened.
That's horrible.
I don't know like what's going on.
Yeah.
It's not, I don't know, I think I was so happy because of the baby and having a baby. And then all of my friends were there.
Oh my God.
And I kind of forgot about it. But I didn't remember that I was in the shower. I never seen it the following day. And I was mad.
Oh, I would be.
You know what, everything's fine.
That's
Everything's
completely negligent.
on this part. You think that he was around and fast so bad. She's great, probably.
Oh, yeah.
And she was, the nurse was so nice to me.
Yeah.
The half an hour after having anything.
Yeah.
She was breathing with me, she was super nice.
That's horrible.
So it was misplaced.
Sounds like it.
Yeah.
You poor thing. I'm glad you survived. Glad you survived it.
And the baby's fine.
Yeah.
That's scary.
Yeah.
I went to my first day, and I just like, I didn't do it. And then he was there, and she just used to like long hair and blue eyes, and really like groomed and everything, and she was like that. And my mom was like screaming at her, like, oh, your husband's leaving you, you got my back. Oh, I apologize. And I felt bad for her, she was kind of like, it's okay, and I'm like, this is her, I'm gonna call her hospital, I'm gonna go to school. And then it was like that extra like this her face, and she didn't look at my face. She had dark shadows, and she's not and I'm like, I was just like, oh my God. I just felt no screaming. And I was like, well, what's that? No, just like, tears don't and so I told her, no, she didn't. It doesn't matter what you do. You always watch your back, always have your back against the wall. Really? That's crazy? What it is. I don't know, right? And everybody's together. I just went back in. And then my other coworker came out and he's like, I'm gonna marry you. She's like, no, I can't. She's like, I'm having things very
We have a disagreement in the group. We have discrepancy among our group.
We're gonna talk about it. We're gonna talk about rationale. It's okay to disagree. It's okay to think you're right. All right, everybody else, sit down. You guys can come forward and sit right here. We can sit as a group. All right, Victoria, what's that? It's important that you get out of the other group. guys to turn around and pay attention now. We're gonna start presenting. Did you make a decision back there? Good for. It's gonna be just this is a group discussion, talking about rationale and why we're doing what we're doing. So it's okay if you're kind of undecided. We'll figure it out up here as a group, okay? No pressure. All right, okay, so group number 1, this is what they were given. Labor patient walks in the door with active labor. Due to contractions for 2 to 3 minutes. Put in order of what to assess first. Okay? Okay, so this is what they had, 1, 2, 3, 4, 5, 6, 7, 8, 9 things. Okay, so who wants to talk? Who's going to write, but who wants to talk about it?
All right.
I want to talk about the rationale, why you're saying you're going to ask her to do water break if they're already bleeding.
Because breathing and we asked that while she's being filled in.
You sure can. These are the things you're going to be exactly speaking out. Takes what, a couple seconds to say ask the question. So good.
Like she said, the feel heart monitor was there includes to check and make sure everything's okay.
So she's asking, so you're asking questions while putting her on the monitor. Okay, we want to get a baseline fetal heart rate. So they're finding the monitor, getting fetal heart sounds, getting contractions, and then from there they're going to get a blood pressure and respiration. What's so important about getting a blood pressure and respiration? We need a baseline, okay? For contractions are 3 minutes apart, we absolutely have to get a blood pressure at what point in relationship to contraction? In between, okay? And they're every 3 minutes. This is a pretty close pattern. So we want to get a baseline BP as soon as we can. It's really important for a labor patient. Because we're ruling out preeclampsia on every patient that walks through the door. Okay, so blood pressure and respiration, then we're getting a temp. We want to get a baseline of temp. Temp isn't as important as this. So we want to get these first and then our temp. And then we're going to obtain a prenatal history, Gravitera. Okay. And then we're putting on our left lateral side. And then are we in a real hurry to do a back exam? Is this in the proper order? Back exam last. What do you think? I would want the strip running all this time before I check her cervix. I'd want to know, is she bleeding before I check her cervix? I would want to know as much information before I do a back exam. The only patient we're going to be doing a back exam is the patient who comes in that's crowning or saying she has urge push or you feel like delivery is imminent. Okay. So, what did you guys disagree with?
They wanted to do the history, like right in the beginning and ask them.
Actually, when you're asking these questions along with this, you can be saying it's your first baby.
Yeah.
I didn't look at it as a question, but obtaining the history is basically finding out how many pregnancies have you had. But definitely knowing this, if she's bleeding or if the water's broken, is really important to find that out right off the bat. Because she's contracting every 2 minutes. So everything else you agreed on? Okay, you did good. So you work as a group. The whole thing of teamwork is that you ventilate and share your rationales with each other. Why do you want to do this over that? Okay, and then come to a consensus. It's really important. Okay, good job, Team Lynn. Yay! All right, Susan, come on up. Okay, I'm going to read what they were given. So 2 hours later, this is the same patient actually the same as his head. You don't know that. 2 hours later, she had 5 centimeters. 5 centimeters, 20% zero station. We now know she's a gravid 1 parent 0 at term. And we also now know that she has a history of grouping stress positive. Okay, so what are we going to do in what order?
We had to assess the heart rate and pattern, UC pattern first. Well, and while the strip's running, patients and ensure the ampicillin. So we said we'll start an IV, then administer 2 grams of AM, and then we can figure out who the support person is and encourage ambulation, because she can walk with them.
Yeah, she can still walk. She's still intact. We don't have, yeah, no evidence. Yeah. So let's look. Assess fetal heart rate and uterine contraction pattern. Good. Assess her pain. What are we asking her about pain?
What are we asking?
Yeah, what are we asking her?
I don't know, we're 1 to 10 things?
Yeah.
I don't know.
1 to 10.
All the things.
How strong is her pain on a scale of 0 to 10, with 0 being no pain and 10 being a lot of pain? Where are we right now? So we want to get an assessment of her pain. Now that we've just found out she's GBS positive, we want to.
Are there, I mean, it really, I don't know what standing order is.
I know.
Like when we start the
I
IV
know,
first, you know?
But normally with a labor patient, we can start an IV on them. There's always standing orders, especially with an active labor patient. But as far as administering the antibiotics, we need an order for that, unless that physician leaves standing orders for his GBS positive patient. So, but when you don't know, you're going to get orders before you start any kind of IV medication. That's important. So get her IV going, get her amp on board.
And I heard, like, establishing who the support person is so that we can talk to both of them about what their options are now.
Yeah.
As far as walking around or saying, and like what this person can do to
Yeah,
help
because
her.
she's 5 centimeters, it's her first baby. If she's able to get up out of that bed and keep walking, the best thing for her to do is walking, but we want that ampicillin infusing. We want the IV started and her amp running. But getting her up and walking her is a great idea. So, and talking to the support person, figuring out who's going to be with her. Sometimes people bring in a whole bunch of people, and we need to know who the actual support person is. And kind of whittle it down, maybe 2 people at the most. Okay. And what would you do next? That's actually, that's not. You already did everything that you're supposed to do. So that was good. Any questions? Any arguments? Any, like, why they did that way? No? Good? Okay, awesome, good job. Okay, good for
Wait, why did they give ampicillin?
So you're GBS positive. We just found
Oh.
out GBS positive.
Got it.
Good question.
Oh, yay.
Pay attention, Joaquin,
Sorry.
Mr. Vice President.
Oh.
No, it's a good question. You missed that. Yeah, she's GBS positive. So we want that in 4 hours prior to the hearing.
Got it.
Okay, so they got 1 hour later, the patient's membrane rupture is thick meconium stained fluid. She's 7 to 8 centimeters completely effaced, +1 station. What does the nurse do next? Okay. Okay, so who wants to explain what you're doing and why you're doing it? Why are we applying a fetal scalp electrode?
We want to check the baby.
Want to keep a closer eye on the baby. Okay, because it's thick meconium, right? What does thick meconium mean? Baby's had a bowel movement, which is a result of what? Stress. The store's been compressed for some reason, for some length of time, and that's when the baby has the first meconium bowel movement. So we want to get a scalp electrode on her. Also, when it's thick meconium, one of your choices is explain to the patient what MEC is. So I don't know where you're putting that, but before you get the scalpel electrode in, I would be telling the patient, I would move number 6 up here, because we want to keep this patient in the know why we're doing what we're doing. Okay, we don't want to just be doing all this stuff and not letting her know why we're doing it.
Do you need
Okay.
a doctor's order for that?
With the scalp electrode, usually with standing orders, if it's thick meconium, that's going to be a standing order. She's already an admitted LND patient. That's a very good question. And it is a nursing action that we can do, is to apply a scalp electrode at our discretion when we're concerned about fetal well-being. So, but my guess is at all 3 of our institutions, a scalp electrode is in order with the patient under these circumstances. Good point. But we want to tell her, the fluid, the bag of water, the fluid is meconium stain, which means the baby had a belly. We want to tell her that. So therefore, we want to keep a closer eye on your baby, which can only be done by the internal self-electrode. And it's a little wire that goes under the baby's scalp. It's a little teeny tiny one that barely goes under the scalp. It'll give us much better information because we're a little more concerned about the baby than we were prior to this. So yes, question.
Can you cause damage to the baby?
What?
Can you cause damage?
Yeah, they'll end up with a little tiny puncture wound. But usually it doesn't cause any damage. It just might be it's a skin integrity issue where we're actually puncturing the skin. And we want to make sure it doesn't get infected, basically. But it's not like it goes deep into the cranium or anything like that. It just goes under the skin barely. Good question. Okay, so we're going to notify the L&D staff number 2. Why are we doing that? Why do we want to notify the L&D staff?
So anyone that comes into the room.
We want everybody to know in this unit now that this is a mess, because you never know who's going to end up in that delivery room. Because oftentimes everything breaks loose at the same time. And so you might be at lunch, and all of a sudden this is your patient, and now she's not going to complete, and they're delivering to come back. So you want to have that coded. You want to alert the desk. We have meconium in labor room 2, for example. Can you put that on the board for me so that everybody's aware of it? Okay, we want that. So when anybody walks in there, especially like the NICU or like RT, I'm sure you've gone a million minutes. So they can look at the board and they can know exactly what room their next delivery is going to be. It's a communication thing. Okay, and then we're going to notify the NICU. And basically by calling out to the L&D staff, we can ask them, can you just let the NICU know we haven't met? But when it's time for delivery, that they're going to be aware that we're not going to We're going to let the ND know and ask to get this amnio infusion. We can't just start an amnio infusion. We need an order for that. So this is good. We're going to let the MD know the water broke. She's gotten that. Can we start an amnio infusion? Offering reassurance, again, this, depending on how your patient's doing psychologically, we might want to bring that up here. Because some patients are like, oh my gosh, So we want to be offering reassurance throughout all this. Because now there's Meg, she's really active, she's getting really close to delivery. So we can actually be offering reassurance to her throughout this whole time. Like, this is what we do, we see this all the time, because we do. We have a lot of meconium deliveries. This is not a big thing to us. We just prepare for this a little differently. We're going to be doing a lot more suction for your baby prior to the birth of the body of the baby. And then after the baby's out, we'll be doing even more suction. We want to get all of that out of the baby's airway. So we're teaching. Check O2 and suction equipment. This is perfect. Unless we get the order. If we call and get that order, we would basically want to start the amnio infusion immediately and get that fluid going, and then making sure that all this is working. Basically, any labor patient in the house should have this working well. When I used to go on duty, any patient I had, I'd go straight over to the warmer after assessing my patient, making sure her IV is fine, her fetal heart rate, all that's fine. I'd go straight over to the warmer, make sure my oxygen works and my suction's working, and I've got the proper tubing and everything's ready. Because you never know when a patient's going to deliver. And the last thing you want to be is scrambling for this on a neck baby, making sure you have the right suction equipment. Because there are different tools to use. Okay, does all that make sense with the meconium delivery? We know why we're doing what we're doing, why we're educating the patient, so they know what's going on, right? Okay, good job. Thank you. Okay, here's for last but not least. Okay, so part 4, 3 hours later, she is complete, plus 3, with an uncontrollable urge to push. The head is beginning to crown. What does the nurse do next?
We had a lot of fun and we had a lot of debate. We've got a couple mothers in our group, and so we thought our big debate was the order of calling and who to call first. There was some of the like, call the MD right away, and then there was some of us that said, call the front desk and have them do everything for you. And so, because they could get you, because we wanted to get another nurse into the room, we wanted to get things set up, we wanted to notify, the other departments of what may be coming. And so we said to call the front desk and call, that was going to encompass kind of all those calls.
Because here's what's happening, she's ready to deliver, and you're by yourself. What is the quickest way to get help? Call out, get the other nurse in there with you, and let everybody else deal with getting the doctor, the team, everybody else you need. Because when you're going to be delivering a baby by yourself pretty much, it's pretty sketchy, let me tell you.
Which would maybe be the case here, right? Because if the
Yeah.
doctor's not around and you're at home.
Yeah. So for me to waste time calling the doctor, I wouldn't waste my time. I know my staff is out there. I know my unit, how many nurses I have, if I have a secretary or not. By calling out to the desk and getting help for me, they can do a lot for me, okay? They can send me a couple nurses if that's possible. But being alone with not ominous, but it could be an ominous delivery. You want to make the least, you want to do the least amount to get the most in return for yourself. So yeah, you're going to call out and get the help and have them call the doctor or get another doctor in. Sometimes their doctor won't be available because all of a sudden now she's gone really fast. So.
And then we thought by getting another nurse in there, you could go back to focusing on the primary being with mother.
And doing the delivery.
Yeah, and the secondary.
Yeah.
Take over the setup, getting the table, getting everything ready.
Because basically, you're right now, you're the provider. You're not the doctor, you're the midwife until they get there. So you need the second nurse in there basically to run your room for you so you can work with the patient and do this delivery. Try to hold her off on not delivering. And some patients don't listen to anything. They're completely out of control. They're just going to push that kid out no matter what. So you want to be there to do the delivery. So this is the importance of teamwork and deciding, okay, what do we do first, what do we do? So that when this stuff happens, you all kind of are on the same page. Okay, so this needs to be like a policy, your department policy, that if my patient is ready to go, I'm going to call it, you're going to help me. We're going to do this together as a big team. So setting up the delivery table. Should the table already be set up on her?
Yes.
I would say absolutely yes. From the time a patient's 5 centimeters on, it should be set. But if it's not set, we need to get another person in there to set the table. Okay, we can't deal with that because we're doing the delivery, right? Instruct the patient how to push. This is what the nurse that's doing the delivery is doing. We're working directly with that patient and allowing everybody else to help us get everything else to work for us. Teach and instruct the support person, absolutely. Are we involving them? Yeah. We're getting them to help us as much as we can, right? They're helping us position, instruct, do everything to help our patient right now. Turn on suction O2 and turn on the warmer. Once I know there's a baby about to come out, I would put this on. If the second nurse comes in the room, you get the warmer on, put the oxygen on, get the suction on, making sure everything's working well. Calling the NICU, again, this job would go out when they call the other nurse. They need to call the NICU for us. They need to call the MD for us. Actually, it's called us like this. They can do all that for us. And so understanding, okay, when I was at Desert Valley Hospital, there was only 2 RNs on at a time. That was it. And nobody said. There's 3 people in the whole department. So we had a much smaller group than working at Kaiser, where we have 8 RNs, a secretary, and OP tech. So you have to know what's available to you, and everybody needs to know. Our secretaries were trained. You get a call to have a medical delivery, they're going to call the NICU for you. They're calling the doctor for you. They're doing all that, and they're getting you extra help. Okay? So for you guys to understand, it's a team effort. Knowing your resources and how to delegate. Really important. Okay? Does all that make sense? Like how we would, hopefully that would work out.
Do they ever prolong labor to make it where the doctor can get there?
All
Because we
the
kind of
time.
saw that yesterday.
We've had that happen
We
too.
were like, what's going on?
Happens all the
Okay.
time. Yes.
Because she was ready to go and said like, stop pushing, and we're like,
Happens all the time with the doctor delivery. Midwives are much more hands-on, user-friendly, they're there. They're not going to ever do that. So they're not push. Yeah, so yeah, that happens all the time. You're going to see it, holding patients off so they won't deliver until the doctor gets there. But unfortunately, as a nurse, as you know, I've done my number of deliveries. We all have. And it's not fun because, they don't pay these big bucks to do that. Because, yeah, you never know what might happen. And you really don't want that liability on you. But it's okay to do a delivery. Okay, so all that helping makes sense? Okay, you guys can sit down. Thank you. Yay!
The rest of them.
Good job, Sue.
One is the staff numbers on them, so.
Okay, that's good. That's fine. No, here. Good job.
Are there male labor delivery?
There was a male midwife I worked with at Kaiser, and all the patients I was a doctor. But he was a male certified nurse midwife. He was awesome. He was a father, he had his own child. So, but other than that, I've never seen any other. Yeah. All right. Okay, we're going to move on to the fetal monitoring. Okay, so we're going to look at these slides first. And so the three people that were in L&D, did they get to look at the monitors? Oh, good. Did you ask your nurses questions about the monitor strip?
Gina actually worked with us a little bit on it.
Gina did? Oh, good. That's good. Sometimes the nurses are into that and sometimes they're not. But always ask to find out if your nurse doesn't mind teaching you some stuff about the fetal strip. This is a picture from your book showing internal, and this shows the internal scalp electrode. Did anybody see the scalp electrode? Oh, you did? Okay, good. So here it is, like a little twisted coil, little wire, circular twist. Goes through, and actually, when you do the body exam, you use the scalp electrode through your two fingers, and you just twist it like that. And just a little tiny bit of it goes under the scalp. Okay, and that's, and then the other one is the intrauterine pressure catheter, and that goes in through the vagina, and then it goes alongside of the baby's head, between the baby's head and the wall of the uterus. So it's measuring that pressure. That's why they want to measure the exact pressure that the uterus is pushing down on the baby. So it's important to understand why we use the fetal scalp electrode. We just saw a good example why. With the meconium stained baby, we want to watch that baby's heart rate much more carefully. And then the intrauterine pressure catheter, that's only going to be used if patient is not progressing, and we want to see, like maybe she's contracting every 3 minutes, has been for 25 hours, and she's 5 centimeters and not moving. So she's on Pitocin, and we're wondering, I wonder if these contractions are adequate. The only way we're going to know that is with an intrauterine pressure catheter. That's abbreviated as an IUPC. You might see it charted as an IUPC, fetal scalp electrodes. You'll see it abbreviated as FSC. So FSC and IUPC. Those are the abbreviations for our internals. Another reason to use an internal pressure catheter is if a patient is really obese. Okay? Lots of adipose tissue, so it's really hard to palpate contractions. So that's a really good reason to use one. If the patient has a lot of extra adipose tissue, we're going to get a much better reading. We won't be like bugging her all the time, moving the external toco around. So these are internals. It's important for you to understand why we use internals. We don't just use them on anybody. On inductions, high-risk patient inductions, we use a lot of internals. because these patients are so sick. We want to have a really clear picture of exactly what's happening with the baby and with the uterine activity. So that was one patient group, high-risk patients, where they're preeclamptic, diabetics, a lot of heart patients. We just want to watch more carefully what's going on with them, okay, before we increase their Pitocin. Okay, then fetal scalp stimulation. Every time we do a vaginogram, basically the baby's head is getting stimulated, and that should cause an increase in the heart rate. If a baby's strip is showing not a lot of variability, no accelerations, a doctor or midwife might say, I'm going to do a fetal scalp stim. That means they're just going to go like this on top of the baby's head and see if they can get the baby's heart rate to react to that type of stimulation. So it just shows that the acid-base balance is good. Okay. And then a reassuring fetal heart rate strip or reactive NST. Did anybody hear anything about reactive NSTs or NSTs? Yes. Okay, non-stress test. Every patient that comes in, we put them on the monitor, we want to see a reactive non-stress test. Okay. Reactive means at the beginning of this strip, the baby's heart rate went up above baseline. So right here, right there in that area, that's an acceleration in the heart rate. That's what we're looking for. And here at the end of the strip, there's another acceleration in the heart rate. 2 accelerations in the heart rate in 20 minutes constitutes a reactive non-stress test. Yes?
We were giving ice water.
Yeah, to get the baby to move?
Yes.
It usually works, and I think it's just the swallowing and the sound that makes the baby like, what's that? I don't really know the mechanism involved, but we used to give ice, orange juice, ice water to get babies to wake up and move around before we let them go home. Yeah, when a patient comes in, we will not let them go home unless they have a reactive strip, okay? Unless they do an ultrasound scan, which is called a biophysical profile. If they can do that test, which we'll talk about more in Module 4, we might let her go. But normally, nobody's going to leave the hospital to just send them home or send them walking without a reactive strip. So this is really something important you need to know. We want to see 2 accelerations in the baby's heart rate. We want the accelerations to go 15 beats above baseline and last 15 seconds. That's considered one acceptable acceleration in the heart rate. 2 of those in 20 minutes is a reactive NST, a reactive non-stress test. Really important. And be asking your nurses about that when you're in L&D. Say, can you just show me a reactive non-stress test?
You said 15 beats above baseline and 15
seconds long. Yeah, 15 beats up and 15 seconds long. That's the criteria we're looking for. Okay. And then this is showing early decelerations. So early decelerations in the heart rate mean early deceleration. Here we have a decel happening, and we have a contraction down here. So the deceleration is happening early in proximity to this contraction. All right, so we have a heartbeat dropping, we have a contraction starting. That constitutes an early deceleration. They should mirror each other. An early decel should mirror this contraction. Okay. These are a reassuring sign that the baby's head is coming down. This is a good sign. We love these. These are our best friends. Okay. We like these. So another early, if we bring it down here, it's when the contraction is beginning. So those are earlies. It's a sign of, this is not any sort of a sign of fetal distress of any type. It's actually good. Mom's progressing. So that's early. And then late decelerations, on the other hand, are something that we get really alarmed with. Late deceleration signify uteroplacental insufficiency. So uteroplacental insufficiency means we have insufficient oxygen getting to the fetus through the placenta from mom. So what's happening is we're stressing the uterus. Here's our contraction, and then we have this contraction peaking, and then as a result of this contraction, we're seeing a drop in the heart rate. So late acceleration, there's something you need to know what they are, and you need to know the nursing actions, what are we going to do to correct this? Because if this goes on for any length of time, we could lose the baby. That's what that means. Because we're getting inadequate oxygen to the baby. And so here's another one, but this decel doesn't go as deep as that one, but these are both just as bad as the other one. Okay, it doesn't matter how deep the decel goes. In fact, some of the most ominous signs I've seen late are very subtle. We call this a subtle late, because you barely notice it, right? You barely notice this compared to this one. Okay, but they're all bad. Doesn't matter. They're all bad, and I think these are worse because these can get missed. And if these get missed and they don't get corrected, then we're looking at a baby that's going to be in a lot of trouble and essentially lose the baby. Okay, so with the late, we would change the mother's position, nursing action-wise. Let's say right now she's having some late and she's laying on her right side. We would turn her over to her left side. We would drop the head of the bed down more flat. We're trying to do everything we can physically with the mom to improve oxygenation. So head of bed goes down more flat to the other side. And then after we move her position, which we can do that very quickly, right? We can switch her, get her repositioned. Then we can start oxygen by mask, 10 liters. It's 8 to 10, but usually when I've had fetal distress happening, I'm going to give 10, the maximum amount, tight face mask. And I explain to the mom when I see lates and I'm repositioning her that I'm trying to get more oxygen to your baby. Your baby is showing me some signs that it wants more oxygen. Just keep it simple. You don't want to freak out your patient, okay? The last thing I need is her getting all uptight and freaked out. So I'm explaining why I'm doing what I'm doing. By you breathing oxygen, it's going to give the baby more oxygen. And I always tell patients, people actually go to oxygen bars and have oxygen, okay? It's really good. It's a great thing. I mean, we all need more oxygen, right? It's good for you. So this isn't bad. You know, I give them a pep talk about how great oxygen is. So, because I don't want her to be scared. If this patient was on Pitocin, okay, we're inducing or we're getting labor going, we would back down on the Pitocin or just turn it off, okay, until these late decelerations are gone, okay? So, Pitocin goes off, we are giving her oxygen after we've changed her position. We can also increase her normal IV fluids, give her some more fluid. And those are our actions. If we can't get these to correct with our nursing actions within about 15 to 20 minutes, we definitely call the doctor. Normally with late, I would try to do my nursing action thing first before I alert a physician, because the physician's going to ask you that. So you have late, what did you do about it? You know what I mean? We need to do our nursing action thing before we're calling doctors, basically. But they need to be aware. If their patient has any episodes of late decelerations, we want to make sure we're communicating that they're aware of it. Okay? So that's late in a nutshell. So late decelerations equal uteroplacental insufficiency. Insufficient supply of oxygen. And these are late decelerations with no variability, absent variability. So basically, that baby's dead. You look at this monitor strip, I know this baby's dead. Okay, there's no variability in the heart rate. A flat, smooth line on a fetal heart rate is a dead baby. Okay.
What's giving that heart rate? Is it false?
It's false. Yeah, it's a maternal. The placenta is still pumping to the baby, but the fact that this is smooth and flat, it's an ominous sign. This is a horrible strip. Like, I look at that and I'm like, whose patient was that? That's awful. So yeah, we should never have absent variability. Never, ever. Okay? Not normal. Okay, then this just shows fetal tachycardia. So tachycardia is above 160 beats per minute. This patient's pushing, I can tell she's pushing by this down here. When she's pushing, we're getting these flat boxy on the strip down here. This is pushing, pushing, pushing. She's getting ready, hopefully, to deliver, but her baby is tacking. So we don't want to ignore baby tacking. And the baby tapping would be something you would alert the doctor or midwife, baby starting to tap. They might want to start doing antibiotics at that point in time. So it's not good. And it's having funny little variables. I don't like them. Okay, then this is called marked variability. See how crazy these changes in variability are. So if this is an external monitor, that can just be artifacts picking up. You don't worry about this as much unless it's an internal. And then it can be a cardiac arrhythmia. Most fetal cardiac arrhythmias correct at birth. But this is something you would want to let the doctor know you're seeing on the strip. Let the NICU know, especially if this is internal monitor. Because this could potentially be a little cardiac baby. And then variable decelerations are the other type of a deceleration that you need to know what they are. So variable decelerations are a result of the umbilical cord being compressed. Okay, so they're cord compressions. So variable decelerations equals cord compressions. For some reason, the cord's being smashed. And it could be wrapped around the baby's neck, which is common. You know, we have sometimes they're wrapped a couple times. But the bottom line is, this patient's pushing also down here, you can see this on the strip. And she's having variables of these pushes. But we don't want, these variables aren't really bad, they're not severe, they're mild variables. But to treat nursing action-wise for variables are, we're going to turn this patient. And the reason we're going to turn this patient to a different position, why do you think we're going to turn her when we see cord compression?
She could be pushing on the cord of the baby.
Yeah, so we're trying to get pressure off of the cord. So there's a different reason why we're going to turn a patient who's having cord compressions as to somebody having late deceleration. Okay. One, we're trying to get pressure off the cord. The other one, we're just trying to get more oxygen to the baby. So understand with the variable, cord's being compressed. We want to take pressure off the cord, so we're going to move mom's position. Okay? So that's our number one nursing action for variables. If the variables become more severe, then we might do, these are really severe, an amnio infusion, add more fluid, which adds more cushion to the cord. And I think class is over, right? And you can finish. Okay, I'm going to let you go. Turn in your vocabulary words up here, please. I'm sorry, I don't want to keep you over time. Any questions? Sorry. So just bring your vocabulary words up here and I'll just check them off, okay? Thank you. You want both of them or just the second one? Yeah. Thank you. Thank you. Yeah. Oh, that's perfect. Thank you. No, you just go to the testing center. Yeah, right there, second floor. Yeah. Okay, you're welcome. Thanks for asking. Oh, my name. Oh, your name. Don't forget your name. Okay, that's good. Okay, that's perfect. Awesome. Oh yeah, Mary's definitely needs to talk to you. Just vocabulary list too. Yeah, perfect. Yeah, Mary's definitely on the skills lab.
Thank you.
You're welcome. Sorry to take You can, and I like to do for that. Bring yours just in case you don't have a lot. I always try to bring mine up, so we have something. Okay, take it. All right?
We did the same thing and we make copies.
List number 2. Yeah, just this one. Okay.
Oh, we did the same thing together. We just make copies.
Oh, that's fine.
That's fine.
Just put it together.
We returned the one from yesterday too, and
There's just one due today. The one we did last week, we went over it. So
I didn't tell them that it was just correct.
that's totally fine. You don't have to check it. Oh, thank you. It's just 3 weeks here. Okay. with the name, complete format, everything. You'll be fine. You'll be fine. Okay, you're welcome. Do you have a stapler? Here, here's a paper clip.
I have a big one.
Are you good? Or you? I usually carry a thick
Last year, I know really crazy, so I had to print stuff up in the lab.
Yeah,
And
it's
no
so good to
stapler.
carry
So
around.
when I was buying stuff, it was like $5. I'm like, I'm getting it, I need it.
It's so worth it, yeah. It's a great good.
And both have one too, I know.
Just two, yeah.
Someone forgot to
Yeah, these were left in the skills lab, and Mary thought they belonged to one of our students. I'll just take them back.
Are you gonna get some?
Yeah, okay. They're for studying. I'll check them off. Yeah, you're welcome. Oh, okay, thank you. That's
I had to write my name on it.
okay, thanks. Oh, good. Yay.
Yay.